All this is Dr MUbeen Syed from drbean.com. Welcome to one more show. So today we have a rock star from South Africa with us. He is actually a rock star and not really the band rock star. He is a medical doctor. He is an entrepreneur. He is a businessman. He is a public servant with his services to public. And he is a hugely influential star within South Africa and world stage. For example, I was reading his bio, and this is I just gonna read a couple of things, and then we'll ask about him from him. So he has been selected as a young global leader of the World Economic Forum in March 2021. He had been selected as one of the 112 young global leaders in the world for 2021. That's a big deal. So, Professor Terrence Kommal is a medical doctor in South Africa. He has a proven history of achievement and he excels as a servant leader dedicated to sustainable and impact focused organizations. He is the founder of Medical Experts Consulting Group. The company and its entities provide services to the South African government for medical work and claims worth more than 2 billion per annum. So I'm going to stop here and I'm going to welcome Dr. Komal. How are you?
Thank you so much for having me, Babine. It's such a pleasure and honor. I'm actually intrigued by the intro, but thank you. I'm not active in much of those platforms given COVID and other factors, the YGL and the others. But we're doing what we can in South Africa because it's all hands on deck.
Got it. So thank you very much. Of course, South Africa is in the news nowadays with a lot of keen positive interest as well. In the beginning, a scare and then a positive interest. I actually feel bad that the world leaders and world had a knee-jerk reaction and just closed down the borders and the flights. Although at the same time, I understand that we are burnt a little bit from the previous decisions as well. So it is great to have someone from South Africa speak with us. So before we talk about Omicron and COVID, tell us a little bit about yourself in your own words. I did an intro. I would like to hear from you. Who are you? Where do we find you? And what are your days look like?
Sure. Thanks so much, Dr. Mubeen. I like to call myself a servant leader who happens to be a doctor, because what's important for me is not just that we work in healthcare or work in the economics or the business of healthcare, but we provide meaningful support and impact to people's communities, families, and lives. And hence my keen interest and focus in looking at the data, looking at the numbers, being up to speed. Because although a lot of my work is from the private sector in entrepreneurship ventures, helping government, serving government in various capacities and different work. I've worn different hats in the past in government boards and government roles, and initially as a government employee in the military. But looking through that lens and experience, I define myself as a servant leader and a father, because every decision we make and every contribution we make impacts people's lives every day. And that is how I see myself.
Got it. Thank you very much. So before we go for the slide deck that you have, I want to quickly, just to keep us on the same page, I'm going to share how South Africa is looking. So this is the South Africa's data. I'm going to focus in a little, and here is the new cases. These are not the severities or ICUs or hospitalizations. These are new number of cases. At this time, for example, December 6th is 10,628. This went up from 200, 300 cases, and it went up rapidly. That kind of scared everyone. At the same time, if there were some folks who started looking at this graph over here, and they said, look, hundreds. So look at this. This is a what? 1,364% growth in the cases. So they kind of use this to say we should all be very worried. And then what I have been looking at with the cool beans. So if you see on the side of your screen, there would be a comments section. You could actually see that there are cool beans and they are talking and they're commenting. So with the cool beans, we've been looking at the data for severity and death, and this actually seems like not increasing, or rather even decreasing. This is November 25 and so on. We would see as this data evolves more, but I wanted to level set us all to say, here is the data that is. Now, please tell us this thing, and I'm going to come back to you and tell me whenever your slides you want to share. The question that a big question that is in my mind is, what is the reality on the ground? Do we have a lot of cases? Number one, are people actually ending up in hospital just like they used to be for with Delta? Do they need oxygen? Are they on ventilators? Are they dying and these numbers are not correct? They come in later. What is happening in the outpatient? There are so many questions. So why not we start with this? Tell us in whichever way you want, how are things in the South Africa at this time?
Sure. To be honest with you, Mubeen, and that is why I think it's important, we share what's on the ground, is what happened in beta, the variant, actually the first phase last year, December last year, and July this year into the Delta variant. There's no signs of that as yet in South Africa. So what we actually have is a statistical panic on the number of cases that we're having in South Africa. And thank you for sharing these slides. If I may, and we'll maybe go into a bit more detail once we skim over some of the important information. To contextualize this for those who are not from South Africa, which is probably most of your viewers, is South Africa has approximately, if I say the formal population of more than 60 million people, given the fact that we have a large asylum seeking and non-citizen population in South Africa that's most likely not accounted for. Gauteng province, which has been considered in inverted commas the epicenter of this Omicron variant, has just under 16 million people. So it's a heavily populated state. But in that context, it only constitutes 1.6% of the population the landmass of South Africa. Based on the information that I have, and I'm collating from various tracking websites in South Africa and government databases, Gauteng had approximately 27,274 positive COVID cases found in November 2021. South Africa as a population had just under 46,000 cases found. So that's to put a background picture, and that is where I think a lot of the panic's coming from. Obviously, in the days after, from 1st December onwards, and the cases had spiked to about 16,000 on Friday, new cases, and then 10,000 on Sunday. So there's a bit of fluctuation at this point. And I will comment later with you in discussion on some of the macro factors that I think that's affecting this. But to contextualize this, there's 136 hospitals in Gauteng province, 96 being private and 40 in public. In terms of admissions, and I'm purposely limiting this data to ending 1st December, because that is when the data went out to the world saying South Africa has a 75% prevalence of Omicron cases on what was sequenced. And we'll circle back on that if you have a moment. But total admissions of a population of 16 million people in the province were only 1,035 people across public and private sector facilities. And if I could clarify that, because, I spent time with some of my colleagues at Columbia, and they struggled with the concept of public facility. We have, in terms of our constitutional duty in South Africa, government-run hospitals that provide healthcare that anyone can walk into. You don't need medical insurance. You don't need funding. You have the right to walk into a public facility for service. And I think it's minimal. We're talking $2 to open a file, even if you can afford it. And that's all you're ever going to pay if you can afford to do that for whatever treatment you need. And that includes acute and chronic. But in the private facility, this is the insured space where people pay for we call it medical aid, which in effect is a private health insurance, which you then use to compensate for your services in the privately held facilities. But to come back to the numbers, there were less than 63 cases in Gauteng province, the epicenter in inverted commas, admitted. Ventilated patients were 27 across 136 facilities, and oxygen support was more needed in the general wards and services for what they had up to that period.
So just a quick comment there, just to put it in the context. When we compare that to Delta, these are, in my opinion, looking at numbers, these are actually low numbers. Am I correct?
To give you an example, Mubeen, without going into too much, I spoke to a colleague of mine that's a cardiologist in a significant private facility yesterday. And to give you a picture of where Delta was, their hospital was full, the general wards were full, the tents outside were full, and they reached a point where people were so desperate for oxygen, they were putting tanks with the passenger in the car, giving them oxygen support in their private cars. It was that bad in one hospital, and across the country, it was that kind of panic in large concentration areas. At the moment, at the same hospital, today's numbers, there's one patient admitted in the ICU for the entire hospital, and it's not a COVID case. So that gives you the
Wow.
contrast of where we are. And although that's a anecdotal of one hospital, the picture is very different from the data that is being shared based on the number of tests and samples, but not patients in beds and patients on ventilators. It's a similar picture in KZN, which is also a fairly largely populated state in South Africa, 116 facilities. In summary, 317 admissions. They've got 11 of the patients in the hospital, 11% in ICU, 5% on ventilators, 27% requiring oxygen. So it looks like there are some symptomatic needs of those who actually do get admitted. But this needs to be seen in the bigger context of these numbers of South Africa has 258 hospitals across the country. In total, there were 1,380 admissions. This is up to the 1st of December. And of that, this is not 14% of the country. This is 14% of the total admission population in ICU and less than 6%. 95 patients, raw numbers, needing to be on ventilators in 258 facilities. So you're looking at a
Again, I want to,
fraction of patients.
yes, please complete your thought.
Yeah, so I think it's a fraction of the number of patients that are being admitted, and to close up this in real numbers without going into too much technical detail. Today, I spoke to colleagues of mine in Steve Biko, which is one of the largest academic hospitals in the province, one of the two larger ones. They've got 4 patients in ICU in the large 8-story facility. Most of those are for oxygen support with pre-existing comorbidities, and they have 11 kids, which is abnormal, but they're not in ICUs. They're in general wards, and ironically, they're not finding respiratory symptoms. They're finding some neurological cases, but the important comment on that is these patients didn't come in for COVID. They came in and these were incidental findings. So the patient may have come in for a bronchial pneumonia or other conditions, and they happen to have found COVID. If you contrast this hospital right now to what it had in Delta, they had 80 patients in ICUs and makeshift ICU beds, and they made ICUs outside to 70 different, almost approximately 70 beds. So 160 people in direct or indirect ICU facilities, and at the moment you've got 4. And a hospital in KZN, which is a large subspecialist facility, the ICU currently has no patients admitted, no one on the ventilator. One patient came in with a heart attack or myocardial infarction. He was moved to high care, but he has eventually been found COVID positive, and 8 kids in the ward. But this doesn't point to the picture, Mubeen, that we're seeing, that we being told to look at based on the testing data.
So, so just to contextualize this and to summarize this for myself, the news that I've been hearing had been too many cases. It is going to be a disaster in another few days as the hospitals continue to or will start filling up with more patients than they would be in the ICUs, on oxygen, on ventilators. There'll be deaths, and this is a huge problem. So at least from the data, again, I understand it is anecdotal, but at least it is coming from the ground. The last
Yes.
2 hospital data points that you shared, they are now, or they were also 1st
Today,
December?
as of 5 p.m. this
That is
afternoon. So
today.
this is 2 hours ago.
This picture does not show, yes, cases are more, but this picture does not show severity at all.
No, no.
And this
In
picture
terms
has
of the
one
state,
more, sorry, just one more point. This picture has one more very interesting thing, and that is Delta has been replaced. Because if there was Delta coexisting with Omicron, then Delta caused severe patients will still be in the hospitals. We're not seeing that.
I agree with you with a caveat saying we're not sure whether at this point we're at the peak of Delta, given that there's been an accelerated vaccine drive. There's been a large amount of vaccine uptake, but there's also been the not enough testing to say it's Omicron, because I don't want to create the inference that Omicron has replaced Delta. What we do have, and that's the data we have, is yes, there's a large number of cases being tested positive. But given the sampling on the sequence of the sequencing data of what was reported to last Friday, and there's no new data out from the NICD as yet, they only sequenced 312 cases. In my mind, respectfully, that's too small to draw an inference. So on one hand, we have data saying we've got 75% of a very minute sample, which we're using to make inferences. We do have a large uptick in numbers being positive, but I don't think we can correlate the two as yet because we don't know what variant in those patients are being sampled
Fair enough.
outside of
Fair
those.
enough. So then tell me this, does the clinical picture within the hospital, does that show some improvement?
From the public facilities, Mubin, and we're talking a tertiary healthcare facility where
Hmm.
patients are being sent, it's the first time that I'm getting information from my colleagues, and it's people who've I've worked with regularly. People
Hmm.
actually it's colleagues I studied with who are saying, Terence, we never thought would come a day where 10 patients came today, were found COVID positive, examined, and 8 of the 10 were sent home today because there was no need to intervene. They were
Hmm.
asymptomatic, they were positive, but there was no need to be in a facility at this point. And they were given a referral saying, come back if something changes, but it doesn't look like you need intervention right now.
That is actually a very encouraging news. So tell me this then, hospitals, their oxygen use, their ICU bed utility, were you able to find some data on that or discuss
Yes.
with your colleagues?
Yes. Mubin, as an inference on something my colleagues and I were talking about, and a good example, my great friend at Steve Biko said, he said, Terence, the easiest measure of where South Africa is right now is what is the oxygen demand? How many liters across a hospital, a region, a province, the country are we pumping per hour or per minute? At this point, he says it's going to be academic to even speculate because there's not enough patients for us to even ask how much oxygen are we using? How many tanks do we have? Because we have more than adequate available right now. We are preparing for a possible wave of serious cases given the large numbers of cases being diagnosed. It's totally not linkable at this stage, speaking today, to Omicron as a variant, but the outcomes in the current clinical picture point to very mild symptoms in what we're seeing, both on the state side, this is talking to one hospital, and on the private sector, as I mentioned in KZN, there's one hospital had a clear picture, and that same hospital group owns at least 3 facilities in Gauteng at this point. And across their facilities today at 5 p.m., they had 20 patients in the general wards and nobody in ICU with COVID cases at this point today. This is limited information. It may change tomorrow, it may change in a week. But given what we're seeing with private facilities in the province, in other provinces, and a large academic facility, there's no correlation between the cases being diagnosed in terms of samples or positive swabs, as we'd call it, to patients with significant change in clinical pictures.
That is very, very interesting. Sorry, were you going to continue with this or we are good here?
It looks like we're good here, Mubin. I think maybe if we
Yes.
just go back for a second, if you look at Gauteng cases in total for November, if we contrast the number of patients, 27,000 positive cases found on swab, ICU
Hmm.
admissions of less 0.2, 0.3%, ventilators of 0.1%, and 0.6% on oxygen support is a really tiny number. If we contrast that with the public message that had been given, 75% of the cases are Omicron, 75% of the cases, and there's almost a panic around immune escape. There's a panic around any information, but that may change if the picture changes. But what we're seeing is there's no gradual change, there's no accelerated change. And we 1 week after that data was put out. So a week later, the picture's consistent for now. And I say this again with caution, because if something changes tomorrow, we don't want to create the wrong impression.
And thank you very much. And I want to add a comment here about the immune escape. I discussed that study that came from South Africa about the more reinfection rate in uh, previously infected, and they kind of implied that this has been in an immune escape. Immune escape is just one part of the overall reasons where the cases may increase. And transmissibility is based on many more factors than just the immune escape. So I continue to wonder when I was reading that study and then I presented it, that it seems like authors or researchers did not have any other possibilities in their mind. There are many other possibilities. For example, if the virus is able to get into a cell fast enough, And if somebody was infected before and their immune system is in a resting state or in a memory state, then it could take some time to ramp up again. Meanwhile, the virus can create symptoms. There are many other reasons as well. And I thought that that was a very broad and, may I say, negative brush to say it is
Yes.
immune escape.
Yes.
Has there been any discussions about uh, this topic there on the ground?
Yes, between some of my colleagues, more in the if I call it the non-lab colleagues, so colleagues who are looking at public health and the broader clinical picture, have been, some of these factors. And one thing you mentioned importantly from the viral load and exposure is, and this is what I discussed with some of my colleagues today, is if a person works in an environment, so a class teacher is working with kids and there's multiple kids who are eventually found positive, the different strain exposures may mean that teacher has a large exposure and a repeated exposure of different strains potentially on a larger time in a closed environment for a period. You'd get the same with nurses and clinicians seeing patients where they're getting regular high volume exposures, which could mean a larger viral load could give you a potentially higher immune response or a more serious outcome at some point. But if you then extrapolate and that and take that back a second, I was at a large in the intra-Africa trade conference 3 weeks ago, and I say this with respect and caution, but many of my colleagues, some of them being heads of states and government departments, heads of significant business leaders across the continent and GCC, when we got to private events and private functions, a large amount of the individuals literally took their masks off because of the misnomer that I think we are to blame as clinicians. Is there's this phrase being passed around of immune escape or immunity passport, and the layperson interprets that sometimes as believing that if you're vaccinated, you won't get COVID. Or if you've completed your vaccines and you have a vaccine certificate, you cannot pass it on or contract it. And I think that's dangerous. If I were to contrast the picture of December last year, in South Africa, it's summer. We're on the other side. So it's time where people are getting out, schools are out, it's school holidays, university holidays. People are getting together like the rest of the world in festive periods. It's warmer, we're socializing. There's a lot of year-end parties like everywhere else. Then, if you contrast last year's apathy after a long year of people saying, yes, there's an uptick of cases, but because of, if I could call it loosely, poor social decisions, besides everything else. And then you look at this year, people have this perception that we're now immune and we're socializing. So why not just not wear masks at all? They weigh it as malicious compliance because you need to wear one in public. You need to be seen one by public officials and police and others. But once you enter a door in a private facility, and you can check on Facebook, nightclubs, parties, socials, year-end events, these, in my mind, are the factors that are increasing transmission. Because at this stage, I have not seen any data out of the NICD or any scientists at this point saying, of the minute sample that we've sequenced of 228 Omicron cases, firstly, they haven't told us how many of those were vaccinated or not. So we can't even make inferences. And of that, how many can provably be related to a mutation and not poor social practicing?
That's a very interesting point. And I want to point out this vaccination status point for the reinfection study as well, because in the reinfection study, there is a statement, one sentence that says, we were not able to determine the vaccination status of the participants. So when they were not able to determine that, they, in a broad brush, once again, assumed them all to be unvaccinated, previously infected. And I think that was also a weakness in the study, which they did not later on admit as a weakness. They just provided that information that, hey, this is one of the data points for you. So very interesting. I have some questions here as well. If you have a few minutes, if you can answer those questions too.
Absolutely.
Awesome. So, Cool Beans, if you had written a question before, it must have scrolled up. Please, if you write a question with a Q or something with it, which I can identify, I would ask those questions. Once again, the answers here, we cannot provide medical advice to your personal situation. This is more of a questions in general and mechanisms and theories and hypotheticals. So please don't take any of this as a medical advice. So I'm going to start with Colin Hamill. I call him Hemi. He's a Cool Bean. Sounds encouraging, but question: would there be more people in hospitals over accidents in work or traffic compared to these numbers?
It's Colin, we'd be speculating, but it's very, very possible that trauma cases are high at this point. What caused that, I don't know. But I specifically had conversations around COVID to my colleagues. So it may be useful in another discussion that we find out what else is there. But with caution, we don't want to traverse into private information unnecessarily so. But I do think it's very, very plausible and possible.
Got it. Thank you very much. Scruffy Scrubs says, any meds used with new variant? Or if I can also add my question to this, is there any protocol differences from previous management to now management? We are already seeing that the outcomes are better. Is there any management change?
I don't think so at this point, given what we've looked at, given the cases and the conversations I've had both with hospital managers, clinicians, as well as the data of the NICD. I don't think it's warranted as yet because given the fact that there's so low admissions for severe or complicated cases, they're even going to look to change anything from what we know already.
Got it. Thank you. Job Lansing says South Africa is not in the flu season. Can Omicron have a worse impact in Europe, America, etc., which are in the flu season?
I do think it could, given the fact that if you're pre-exposed to the influenza virus or anything else that's impacting your immune system, you may either be having an aggravated immune system that may cause an earlier and more aggressive response, or you may be recovering with a already overburdened immune system and have Omicron or just COVID itself. What is interesting, though, is if we look across the EU or Europe or UK, given the fact that the variants are now being found, and again, I say that with a caveat of we don't know what volume is being sequenced. We're only getting raw numbers of how many they found, not how many they sampled to find those raw numbers. But if we need to contextualize that, seeing that the numbers are in tens of thousands and large factors more than South Africa, it's very likely they may have more Omicron cases eventually and complications even sooner than South Africa. And I say that with caution, given if I'm just purely contrasting numbers.
Got it. Thank you very much. Blank Blank says, would like the professor to characterize the accuracy of South Africa C19 reporting system. The low rates relatively is being characterized as poor reporting testing.
If I understand it correctly, if the question is low rates being the cases and poor reporting and testing, I think they're two separate systems. At the moment, there's no sharing of information between the lab systems who are doing the sequencing and the clinical picture because of privacy laws like you have HIPAA and we've got POPI and others. I don't think there's a direct correlation between the two. And just this evening, I discovered that government has become very protective of the vaccination data because people are trying to say, let's compare admissions to vaccinations to the Omicron and other sampling. And from what I understand this evening, and it may change, I'm told by my colleagues that government has said, sorry, we're not sharing any information from the vaccination system.
Got it. Thank you very much. And for the audience, when I'm looking here, I'm not looking away or not paying attention to you or our guest. I'm just looking at the comments to see what is the next one. So apologies for this gaze away from you. So quick question. JLB says, from today's data, we can assume that Omicron is less dangerous, question mark. Is it?
I don't know if we can make such a broad finding as JLB in the context that we've only, in terms of the data reported from the NICD, there were potentially 45,000 positive find cases or swabs, if we could call it, in South Africa for November. They only sampled 312 cases and found 228. There's not enough data at this point that I can access or anyone can access at this point till there's something published later this week to say that it is Omicron that's being found dominant or not, or inferred so. All we're saying is we're finding positive COVID cases on PCR. We don't know whether it's Omicron and we don't know if it's not at this point. The sampling has just been way too small compared to what we did during Delta.
Got it. Thank you very much. And you are actually such a brilliant guest. I would wish to have you every day and do a co-show with you. So here is James Maddox. Can people get the long hauler condition from the Omicron variant?
I'm going to speculate, and I say this with caution, is I'm not sure if you could get long COVID because we don't have enough proven cases that have been followed up for a long enough period because it's too short. We won 2 weeks from the announcement. We'd need 3 to 6 months down the line. But given the picture of COVID in general, there is a possible likelihood that there could be long-term symptoms. But as and I think my friend Mubeen is more the expert that I've learned from, is given the number of mutations on this variant, there's a lot that could change in any direction. We just don't know enough at this point.
Got it. Thank you very much. This is a very interesting question. Barwood says Omicron is in Australia. Only vaccinated can go to Australia. So it had to have been a vaccinated person that brought it. So is it possible only the vaccinated get Omicron?
I don't think so. Because even if you were vaccinated, it's not only passengers that travel. There are people in other modes of transport, and I'm not sure how robust the investigation system is, and that's talking to a public healthcare screening system. I agree with you, and I follow your line of logic. Is it's most likely someone who's been vaccinated, but I'm not sure as yet. I don't think there's enough information to say anything.
And if just to quickly add this, some of the data points that we have been discussing in the past few days, there have been reports from the hospitals where Omicron patients have been vaccinated and unvaccinated. So I think
Yes,
it's not specific to vaccinated, but
indeed.
vaccinated are getting it.
Yes. Mubin, just to add to what you said, if I may, just an important point to me is there's currently no centralized sharing of vaccine information. I've done a lot of travel well, actually just to Mauritius in the last 2 months or so. And the PCR systems, there's no way to validate whether it's a genuine PCR test. There's no way to validate if that vaccine certificate is genuine. The fact that it's in color doesn't change that. I've seen in the two different airports that I've seen in South Africa and in Mauritius, some people show their PCR results on their phones. Some people show hard copies. It's very possible that some could be fake reports, and hence there is a likelihood that unvaccinated individuals with fake reports could fall into this basket of being able to carry Omicron.
Got it. Thank you. So there is actually a good question. Give me 1 second before this one. Claire Robinson says, "Looks like a very professional setup." So she's talking about yours. Nice mic. Does he do a podcast? Looks like you do a podcast from your setup. Tell us more.
I was doing podcasting till about early last year in an organization called YPO, and just a personal anecdote of why that stopped is regrettably unrelated to COVID. I lost my father in the middle of July last year, and he was sick
Oh,
for a
very
very
sorry
short
to hear
period.
that.
And thank you. And I think that changed a lot of my perspective. So I withdrew from a lot of my public engagements, focused on my family as much as I could. And given the last 2 3 months, I've now settling back into contributing publicly and other platforms. I'm starting to use our setup. But thank you. I appreciate the compliments.
Thank you. Thank you. And once again, sorry for your loss. Bob FWD says, "Are you seeing a huge spike in kids getting infected? What are the symptoms?"
At this point, I don't have enough data to comment on it. What I did find today, and again, please, this is very limited in anecdotal evidence, is a colleague of mine mentioned to me the patients that are being admitted, particularly the kids, they're not being admitted because they got COVID and needed somebody to look at them. They were being admitted for other things. So they admitted for a pneumonia, they admitted for a diarrhea, they admitted for other healthcare conditions. And the fact that when you need to be admitted into a hospital, you put into a person of under investigation ward, you must get a COVID swab. Once you get the results, they transfer you. In that process, they happen to be finding the COVID cases. I'm not saying there are no COVID cases only. I'm talking about 3 facilities that I've discussed with, but they're sizable facilities. They've said this is what they have, and that's only correct at South Africa 5 p.m. time today.
Got it. One more question. Doug Gold, could the numbers be way underreported due to low severity of symptoms?
If we, and I'm going to try and qualify the response, if we're talking numbers underreported of positive cases, I don't think so, because the central database is tracking the number of patients who are testing positive for COVID. But I don't think there is a correct answer of when we say reporting numbers, we could correlate that with the number of people being admitted. What I have and what I'm sharing is what's happening on the ground today in these hospitals, but I don't know whether we're being able to correlate the two. I think that's a question on everyone's mind right now.
Got it. This question, once more, I think we touched on it a few minutes ago. What early treatment has South Africa's doctors used to treat COVID 19? So, are you aware of any protocols? How do you manage?
I don't think there's anything outside of what is general consensus internationally. It's symptomatic supportive treatment. It's the usual protocols of a cocktail of vitamins that's being given orally or IV. And most focus is on reducing symptoms, inflammation, and where necessary and at an appropriate time, steroid intervention and other treatments. But again, that's in cases where warranted. I don't think we've deviated as a country from the general global consensus.
Got it. So I got to say that you are getting a lot of positive comments on the from the cool beans over here. You are actually an eloquent and to the point and very charismatic speaker. So thank you very much for giving us your time today.
No,
Let's
thank
see if we
you.
can. I am still struck. I think we would love to have you with us maybe next week as well, just so that we can see data beyond the 1st of December, and we could have our eyes on the ground to see what is happening. It would be great to have you with us once more.
Absolutely. I'd be very happy to share Mubeen, particularly trying to correlate the clinical pictures in facilities to the raw numbers, if I could call it, or the panic related positive swabs, as opposed to poor outcomes at this point.
Excellent. Thank you. So I'm going to go back to some more questions, couple of more questions, and then based on your time, we'll discuss further. So Umari Wheat says, are you all still noticing an absence reduction in symptoms like loss of smell and taste?
Given the cases that and the reports I've looked at, given the information that I have, there's not been a prevalence of the loss of taste and smell at this point. Given the cases that I've looked at, and this is one lab, one private lab, which is about 20-30% coverage of the population, they followed up particular cases from the first cases that they had diagnosed through. And I'm told by the pathologists who were talking to the treating physicians that most of these symptoms in these patients that they followed were vaccinated, one, and those symptoms were limited to upper respiratory tract. So if I could call it very flu-like symptoms, very, I wouldn't want to traverse a pneumonia-like, but it's limited to the upper respiratory tract, but there's no loss of taste and smell. So there's no major neurological implications at this stage, but I want to qualify that it's anecdotal.
Got it. Still good news so far. A couple of more questions. Bob FWD says, and totally up to you to pass on any question that you think is more on the non-medical side. Do you think that these travel bans are justified, or is it just penalizing the good work done by doctors there?
I think it's more than that, Mubin. The first answer is no, they're not justified. It's extremely almost archaic kind of thinking that one would say comes from a colonial perspective or a north, south kind of disjoint, which is really frustrating for everyone. I don't think it's only penalizing the work in South Africa, but it's penalizing the population, the people, the economy out of fear and panic. But nobody's seeing the broader picture of saying, when you said South Africa has Omicron, we got to lock you out. At exactly the same time, the UK numbers are north of 50,000 cases a day. There's just no common sense or science sense to justify the knee-jerk reactions that we had. And I don't think it is justified then, and it's not justified now. I think the travel bans need to stop because uncertainty is not grounds for almost, if I could call it loosely, sanctions against countries in a particular region, more especially when they've demonstrated they are able to do the sequencing and come forward as quickly as they did. What is important to consider is I'm not sure if other countries did the sequencing but wanted enough data to be able to make a call, understanding the macroeconomic changes and implications before they called it. In South Africa, there was obviously a push to say we did it first. I don't know if there was enough at that point. It's nice to say we did it, but we had to quantify that in a controlled strategic communication process, which I don't think was 100% effective in the way we did it.
Got it. Thank you very much. Two more questions. Robin Hood 46 says, if the central database is controlling the numbers, surely the vaccine status is a known. I think
Yes.
this is to that various studies that are saying, hey, we do
Yes.
not know the vaccine status yet.
Yes. See, we have a system called the EVDS system, the Electronic Vaccine Database System, that's controlled by the Department of Health, which is the central health administrator and policymaker in the country. They run the healthcare system from policy perspective, and they run the public healthcare facilities, but not private healthcare. But the data is being controlled, as is vaccine purchasing and vaccine rollout, centrally from government for obvious reasons. Why they don't want to share the data, even if it's anonymized, I cannot understand at this point. Because I think to help the country, the department, and the world, if we could be able to overlap the number of cases of vaccines to the number of cases being found, and also at some point maybe be able to correlate who's being found positive and who's not on the new variant, whether it's Omicron or they're getting reinfected with the same variant or a different variant, would be very useful at this point. Why there's a resistance, I cannot understand. But I also need to comment that a lot of the data and sequencing that South Africa is doing, and you'll see that on the NICD slides, is not going out from South Africa alone. The South African NICD data goes out to GISAID, gisaid.org, for validation, as they call it. And in effect, from what I see on the slides, the copyright of the data is now being held by GISAID, which again is perplexing to me. There's too many moving parts and not enough answers at this point.
Got it. Thank you very much. One more question. Moonchild says, is it possible Omicron has been around for a while and not discovered due to a mild symptoms?
That would most likely be true for across the world, right? Because we don't know which countries were actively looking to sequence as opposed to keep their patients well and alive. Using UK as case in point, if you're seeing 50,000 new cases a day and I have no idea what the clinical picture looks like on the ground, will there be a focus of trying to manage positive cases in the context of Brexit having taken place recently and the political movements, and contrast that with festive season and wanting to do sequencing? I don't know, but it's very possible Omicron has been everywhere else. And I'm sure many of you have followed the story of people are saying they went to an anime conference in the US and the UK and elsewhere, and people have traveled. And most likely Omicron was already traveling before South Africa even announced the variant. I don't know would probably be a safe answer.
Got it. So with this, thank you so much. So the last message to you once more, and I would request you to join us next week as well, if you can please find some time. And for the cool beans, before we close, we will not have an evening talk today because I want to leave this video for the newcomers who would see it. So Terence, what is your message? Hope, uh, don't know yet, and how do we find you if the cool beans are trying to find your podcasts or your talks? How do they reach you?
Sure. I think if you search my name, I've got a channel on YouTube that I'm working on developing at this point on YouTube. So it's Dr. Terrence Kommal on YouTube, the same on Facebook, LinkedIn, and other platforms. And I'm very accessible in most times. If you hit me up on LinkedIn with a message, or Facebook, or YouTube, any of the platforms, I'm more than happy to respond as much as possible, given the context where we are. But in summary, my message to all of you, using the Sanskrit words of Vasudeva Kutumbakam, the world is one family. We're one family at this point, and I think COVID has reminded us again of we are one family. We're in this together. This is not an Africa problem. This is not a South Africa problem. It's not a UK or a US problem. It's a humanity problem. We all are equally uncertain. We're equally frustrated, and we're equally burdened by the uncertainty of this pandemic. What is in our control is to remain responsible, particularly in this festive period, because I can tell you, even in South Africa, and it happens at events, and sometimes I'm hosting those events, is people wear their masks out of courtesy when they enter your door. But the first cold drink or the first tea or some refreshment they have, the masks go off and most likely never go back. Please consider that the decisions you make now will impact your family members and those who may be more vulnerable than you at this point. And your decisions may help you make the decision whether you can contribute to them seeing another festive season or not. This is not being negative, it's being realistic. Let's control what we can. Let's sanitize, wear our masks, socially distance, and take conscientious decisions. What we can control, we can. We cannot control the mutations or the variations, but we can control that we are all in this together as one global family, and we all have an equal role to play.
Thank you so much. Very well said. And I'm into your message. So, once again, thank you very much for being with us. Hopefully, we'll have you with us once again. And Cool Beans, thank you very much for being here. Bye
Thank
bye
you
for
so
now.
much. Pleasure and honor.
Thanks.